as far as loading or even just objectively testing something like strength, do you use any type of objective, talk manual muscle testing, I'm assuming I know your stance on that, but do you even use that as a way to elicit symptoms as just a quick screen, push and press, and hey, hold here, just to get an idea of what their tolerance is? Yeah.
Yes, I do. So, again, I just know it's not specific to any individual muscles. I think the best way is I manual muscle test movement, not muscles. So I will manual test an abduction movement. I'll manual test an external rotation movement. I'll manual test a forward flexion movement. So I manually test movement, not muscles. But I also, if I want a bit more objective data, I'm not averse to a handheld dynamometer. I think sometimes getting a bit more objective data is good for some of these tests. For some patients, that they can buy into it more when they can actually see some objective deficits from one side to the other. A lot of people will say, well, that doesn't relate to anything. And I'm like, yeah, I know that. But some patients, when they can see one shoulder is 25% off compared to the other one, it motivates them. And then they come back next week and say, right, I'll do that test again and see if I'm a bit stronger. Like, yeah, good. And they're buying into it. They're getting their sort of feeling that they want to do something active about it. So I do, use handheld dynamometry quite a bit in clinic as well.
So for any of the students listening, MMT, manual muscle test, just change it. Manual movement test. You don't even have to change the acronym. Boom. This is boom. Yeah. And so what you're saying is with the dynamometer, objectifying, because some patients like that. It creates buy-in. There's some competitive nature there. If we're dealing with athletes, give them something to look forward to and to change.
Absolutely.
And the rebuttal would be, okay, Adam, well, show me the prospective data that matters. What's the cutoff? You're scoring something. You're making somebody relying on a number. I feel like the same arguments could be made for other things like manual therapy changes or range of motion, but I find that at least we're tracking force production. At least we're tracking something that could be an attribute that's useful.
Exactly.
Right.
And again, there's a little bit more objectivity behind it than just a visual analog score or something along those lines. So I think, I get these complaints thrown at me as well. So why do you use a handheld dynamometer and give figures like that when you're not specific about anything else? Well, say because it's useful for some patients to get them to buy in. It gives them a goal. It motivates them, and it is interesting to see progress through that 3-month process. You can see somebody, with a 50% deficit, completely eliminate it in time with loading and exercise. The question is how have they done that? Is it the exercises that's increased the strength, or is it just they've reduced pain and therefore they can generate more strength because they're not in pain? I don't know. I don't care.
Yeah, I've heard Eric Mara say a similar thing about strength, how strong, so being strong is a protective mechanism or a protective shield from pain. Not necessarily, there's no cutoff, how strong is strong enough. I know here at our gym, I've worked with people who can squat 900 pounds that have hip pain. So it's how strong is strong enough? So it's but for somebody, general population, there seems to be something to the process of strength training, the process of being more resilient to stress. It seems like there's something there.